The NHS has invited 50 partnerships across the country to be part of the New Care Models programme. Through the New Care Models programme, a complete redesign of whole health and care systems are being considered to improve the care people receive. The partnerships, known as vanguards, will link local health and care services together, reducing variation and improving efficiency. There are currently 5 types of vanguard: integrated primary and acute care systems, multi-specialty community providers, enhanced health and care homes, urgent and emergency care and acute care collaborations, all are aimed at improving patient care and services provided to local communities. Different models are being trialled in different areas throughout England. The results of these pilots could mean fewer trips to hospital. For example, with cancer and dementia specialists holding clinics in local surgeries, having one point of call for family doctors, community nurses, mental health and social services, or access to blood tests, dialysis or even chemotherapy closer to home. It will also join up the often confusing array of A&E, GP out of hours, minor injuries clinics, ambulance services and 111, so that patients know where they can get urgent help easily and effectively 7 days a week. Many vanguards are starting to show benefits for patients and local communities, including the provision of specialist services for serious emergency cases every day and improving the clinical and financial viability of hospitals. Each vanguard will receive support to enable effective change at pace. This will help inspire the whole health and care system, improving the care received by millions of people across the country.
Cancer care in Greater Manchester is going to radically change in the next few years. Hospitals, GPs and patients are joining forces to save more lives, improve treatment and make sure patients have a better quality of life. Patients are at the very heart of this new service and we really need to listen to patients and see what they think is important in the design of these new services.
My name's Bex. I was diagnosed with Hodgkin's lymphoma in 2004. I was 17 years old at the time. My overall experience of being treated for my cancer was really good actually, but the beginning part that I didn't get diagnosed straight away, it took actually a few years, and by this point I was stage 4 when they caught it. For me, it would have made my whole experience so much easier if I'd been diagnosed at stage 1 or stage 2, because then it would have cut my treatment time in half. If I was going to my GP a number of times and he wasn't picking up on something that I felt was quite serious, then I definitely think that another system put in place for me to go and get a second opinion or seek help somewhere else would have been really good.
My name is Saeed and I was diagnosed with rectal cancer 6 years ago. One of the things that I would like this initiative to look at is the psychological effect that having cancer has on patients. I would have loved to have had a list of 50 patients which have been gone through exactly the same as I have, so I could communicate with them. For me, the solution would be to put patients in touch with patients. They are the same. They can talk to each other like cancer patients, not like doctors and cancer patients.
Hi, my name's Mark. I got colorectal cancer when I was 31. As a patient, I would have liked to have had all the options there and had them discussed. Some of them are quite complicated, but I want them made easy for me, for the patient. I need to be involved in decisions about the rest of my life. And it's not just about saving my life, it was the quality of life after cancer that is important to me. The saying is, no decision about me without me. And if we can get that into our cancer system and our pathway, all the good work that everyone does will be made better, because the most important person, the most important ingredient will be added to the mix, and that's the patient.
My name's Vanessa, and I was diagnosed with squamous cell carcinoma. This is a tremendous opportunity for Greater Manchester to move forward not only with early diagnosis and treatment of patients, but also to consider what happens at the other end of the spectrum as regards rehabilitation services. In the future, we will have a greater number of people being treated and recovering from cancer, and they will be dealing with late effects of cancer. And rehabilitation is going to be key, and Manchester has the opportunity to take that forward also.
My role in the Vanguard programme is Vanguard Programme Director, and it's my responsibility to lead, mentor and support the staff to gather learning which we can share with the wider NHS in our toolkit. So this year we've been learning from our own network, doing a look back and learn, as well as from other networks around the UK and abroad about single specialty network care. We're in the process of developing a toolkit which will be in the form of an e-website, and we'll be launching this on the 3rd of April so that it will be accessible to all other NHS organisations and the wider community. We will publish the website address to enable people to access the toolkit, and we'll be having a big marketing launch. Besides developing the toolkit, the Vanguard programme has delivered other benefits to the wider team. We've all increased our learning, we've developed great network relationships, and we've grown significantly in terms of our own development.
We were very interested in becoming a vanguard because we'd already had a history of collaboration, not just a collaboration between the 7 acute providers within the footprint, but also with our commissioners. And our vanguard is a collection of clinical and non-clinical services across the footprint, which are considered to be standard services that we would expect in most hospitals, not super specialist services. The advantage of being a vanguard is that it would give us a national support and recognition for the work that's been going on, and also a national sense check that makes sure that we're on the road to delivering better services that could be applied to the rest of the NHS. We have a number of clinical and non-clinical models that could be replicable throughout the NHS. If I was to give a piece of advice, if one is trying to adopt one of these models, it's not to ignore the local context. While some of the models can be directly replicable, there will be some nuances within footprints and organisations which may need some careful thinking before the model is adopted fully.